Nau mai, haere mai. Welcome to this module from the New Zealand Dementia Foundation's Dementia STARs education series. Dementia STARs is a series of 8 modules covering some of the most common topics that caregivers work with every day when supporting people living with dementia. You are an extremely important part of the network of people who work in dementia care, and we hope you find this course very helpful for your work. Did you know that people living with dementia have a much higher risk of delirium? Delirium can be a very scary experience for everyone involved, and it can have a serious impact on the person who has it and those around them. The good news is that there is a lot that we can do to recognise and prevent delirium.
Tēnā koutou, e tipu aki ao ke murahiku, ko G te whānau, ko Susan toko ingoa, ko tēnei taku mihi ngā tangata whenua o te rohi nei. Ka nui te mihi kia koutou, nō reira tēnā koutou katoa. So glad you can join us for this session on delirium and dementia. I'm Susan G and I'm a dementia researcher and educator. I'm also the liaison officer for the New Zealand Dementia Foundation. Delirium is common and serious, but thankfully often preventable. So what is delirium? Let's hear from Dr. Matthew Croucher as he gives us a brief introduction to delirium.
One of the questions that you may be thinking is, how can I explain to someone what the difference between delirium and dementia is? They're both Ds, we know they're both to do with confusion somehow, but what actually is the difference? A simple way that we could explain it to, say, a family member that was asking us is that whilst dementia is a long-term problem, it is chronic brain failure. It is the brain having trouble doing its normal jobs, but over a long period of time. Whereas delirium is acute or short-term brain failure. So it can actually look very similar, but the difference is how quickly it can come on and then that it will go away again. So delirium, short-term, caused by something like, say, a bladder infection or a cough or a cold or the wrong medicine, and will hopefully fully improve when the person has come through that stress on their brain. Now here's the snag. Who do you think in the city that you work in is most at risk of developing delirium this week? It's people who already have a vulnerable brain. That is, people living with dementia. So most people in your city right now that have delirium are also living with dementia. So that just makes it quite tricky sometimes to work out what's going on, and the secret is to look for a change. And having implied that we might be able to fix it by fixing the bladder infection or fixing the cough or the cold or getting rid of the medicine that caused it, you might be wondering why it's such a problem. But actually, delirium turns out to be a really serious condition. So I'll run you through the problems that I end up looking after people and trying to help them with in my job. So one of the problems with delirium, especially if I have a dementia at the same time, is that whatever was bad enough to cause me to become delirious may be bad enough to cause another step down in brain damage and brain function. Permanently. In other words, I'll recover, but not to the same level I was before I started. The second problem is, did you know that if I've had a severe delirium, my chance of dying in the next year is greatly elevated compared to those other people with dementia who have not had a serious delirium. Another problem, and perhaps the one that pulls at our hearts the most, is that delirium is a tough ride. Delirium is a scary thing to go through. You wouldn't want it for a day, an hour more than you need to have it. And the fourth thing is, if we don't see delirium as really important, then we won't focus on the most important goal, which is preventing it, rather than just helping someone to have a better ride if they've got a delirium. Prevention is key. So those are the main reasons why delirium matters.
As Matthew said, if we can spot the trigger for the delirium and get on top of it, the delirium itself will often clear up in a few days. Now we might think, what does it matter if Mrs. Smith is a little confused? But it does matter, doesn't it? Delirium is serious for people living with dementia. Delirium affects well-being. Delirium can be frightening and distressing for the person and those that support them. Delirium is a big risk factor for falls. Research shows that when teams successfully reduce delirium, they also reduce falls. Delirium can affect cognition permanently. Some people living with a dementia won't return to their previous levels of cognitive functioning after having had a delirium. On average, the rate of cognitive decline is steeper after having had a delirium. Delirium affects futures. People living with dementia who develop delirium are more likely to need help walking, are more likely to be admitted into hospital, and are more likely to die within the next year. People who have had one episode of delirium are more at risk of developing delirium again in the future. We'll be looking at 3 key messages today: suspect, support, and prevent. Our first key message is suspect. As care workers, you aren't expected to diagnose delirium, but what is enormously useful and important is for you to be suspicious. And if you suspect someone has a delirium, report it to the right person. But what does delirium look like? Well, for someone living with a dementia, we see worse than usual confusion when they have a delirium. It's a change from what's normal for them. The symptoms develop suddenly, usually over a few hours or days. And delirium makes it hard for people to pay attention and focus their thoughts. There's a change in how alert or awake people are. The person might fluctuate between being more confused and seeming okay all in the same day. Now, delirium can look very different because there are different types of delirium. Some people have hyperactive delirium. They're restless and agitated. The delirium is winding them up. The person may have hallucinations or delusions. They may be seeing things that aren't there, like spiders climbing the wall, or they may believe things that aren't true, like thinking that people are trying to poison them. We may see more care issues because the person's getting upset when we're trying to provide personal cares because they don't understand or because they're misinterpreting what's going on. For example, I know of one gentleman who believed he was going to be gassed to death in the shower. You can imagine how strongly he fought because of the reality that he was in. We may see sleep issues with the person finding it very hard to settle down to sleep at night, and when they do sleep, they may have nightmares or night terrors. Hyperactive delirium can be really distressing for the person and for those that love and support them. Some people with delirium have hypoactive delirium. They're quiet and sleepy. It's almost like they've been sedated. It may be harder than usual to get them to respond to us. They may move less and eat less. Some people have mixed delirium. They go back and forth between being agitated and being sleepy. So which type of delirium do you think would be hardest to spot? Yeah, it's the hypoactive delirium, the quiet and sleepy type. That's really easy to overlook. But in fact, this type of delirium tends to have the worst long-term impacts. When we're supporting people living with dementia, we have a situation where the delirium is superimposed on top of existing cognitive changes. Now that can be hard to spot. Delirium symptoms can get misinterpreted as the dementia getting worse. So, to go back to basics, dementia is an umbrella term for chronic, progressive changes in the brain. There are over 100 different types of dementia. The most common type is Alzheimer's disease. Some of the other types of dementia that you may have heard of are vascular dementia, frontotemporal dementia, Lewy body dementia, or mixed dementia. The thing is that all these types of dementia have a gradual onset. There's a slow progression of cognitive decline across time. In contrast, delirium has that sudden onset. It comes on in a matter of days or sometimes even hours. With dementia, you're asking, are they different from last year? With delirium, you're asking, are they different from yesterday? One of the hallmarks of delirium is that problem with attention. If you ask someone living with Alzheimer's type dementia what they had for breakfast, they might say, I can't remember, or they might say cereal, even though you know they had toast. If you ask someone with delirium what they had for breakfast, they may not reply at all because they can't concentrate, or they may say something about those pesky spiders instead because they got distracted by them. We do see some variation across the day for many people living with dementia. Many people are at their best in the morning. But with delirium, we see new and more dramatic fluctuations across the day, with the confusion and the other symptoms coming and going. When a person living with dementia develops delirium, the delirium symptoms overshadow the dementia. So, let's meet Judy Jones and her daughter Karen. We're going to be following their story for the rest of our session. Judy Jones is an 85-year-old retired preschool teacher. Her husband Joseph died 7 years ago. We're going to imagine that we're Judy's care worker. We're also going to meet Karen Jones, who's Judy's daughter.
I'm Karen Jones, Judy's daughter. My mum is a remarkable woman. When we were children, she stayed home with me and my 2 younger brothers. We had so much fun as kids. When we were in high school, Mum started working as a preschool teacher. She worked there for 25 years. She really loves children. Mum and our dad both retired at the same time. For the next 10 years, Mum and Dad spent a lot of time travelling and working on the house and garden. They were so happy until Dad had a massive heart attack. Dad's sudden death was difficult for all of us, but it was so hard for Mum. Initially, Mum seemed to do better, but then I started to notice her forgetting things. We joked about it at first, but then it wasn't funny anymore. 2 years ago, I had to take over paying the bills, something she had done for over 50 years. She forgot to pay some of them, and the power was almost turned off, and it turned out it was just too complicated for her. Then I noticed that she would just keep wearing the same unwashed clothes when she was always so careful about how she looked. Eventually, she agreed she needed more support. I feel so bad for her. She knows her memory is fading, and she can't do anything about it. Mum had a bit of a cough when I visited today for morning tea, but we had a lovely chat about some of the trips she and Dad went on.
Hello? I'm Judy Jones. I heard somebody ask if I was here. Hello? Judy Jones is over here. Karen. Karen? Are they looking for me? Karen! What kind of a place is this? Oh, Karen. Karen, they have children hiding under the bed. Maybe they can help us to find little Susan. Oh, she's always hiding. Susan! Susan! What is that beeping noise? Can you help me find Susan? Karen! Get me out of this place! Karen!
So when you were watching the video, what did you think was going on with Judy? If you thought delirium, you were right. Judy's experiencing delirium superimposed on top of dementia. How could we pick the dementia? Well, Karen talks about long-term cognitive changes, doesn't she? Things that have progressed across several years. We heard about the memory problems, then having difficulty with the bills, then having difficulty choosing appropriate clothes. What about the delirium? Why did we suspect that? Judy's very clearly different than the picture that we get from Karen just last week, where they were having a nice chat. Judy's agitated and distressed. She's confused about where she is and whether her daughter is there. She's seeing and hearing things that aren't there. So the big question we ask for delirium is, are they different today? Has there been a sudden change? So thanks to our report of the change in Judy, the GP visits. It turns out that the cough is aspiration pneumonia, and Judy's also diagnosed with a hyperactive delirium, superimposed on top of her existing dementia of the Alzheimer's type. So now we have a diagnosis. How can we support someone with a delirium? Judy's obviously distressed. How could we help settle and reassure her? Should we start off by telling her to calm down and repeating that there are no children under the bed? It's all in her head. Obviously not. The experience is very real for Judy. That approach is likely to end up as an argument we can't win, and Judy will be even more upset and not trust us. Our key strategy is to respond empathetically to Judy's emotions. We don't argue about the facts. We let Judy know that we can see how upsetting this is. We reassure her that she's safe and that we're here and we want to help. But we don't need to lie. We don't have to pretend that we can see the children too. This usually doesn't help anyway. So we're going to keep calm even when she talks about things or events that aren't real. In this scenario, we might invite Judy to shift from her bedroom to a different room. That might actually help Judy to remove herself from the experience of those children under the bed. We ask Karen to visit or to talk to Judy on the phone. Judy's calling for her daughter, and the presence of Karen can be a very reassuring thing for her. Judy has a hyperactive delirium, and she's over-alert. So overstimulation can wind things up further. There might be some ways that we can reduce the risk of Judy feeling overwhelmed. For example, turning off the TV and radio, reducing bright light, or just having one support person in the room at a time. If Judy wants to move, we'll help her to do this safely. We don't want to get into a cycle of repeatedly asking Judy to sit down, sit down, sit down. That may wind her up even further. Gently, we're going to remind Judy about who we are, what time of the day it is, and where she is. Delirium can cause a person to act out of character. So even though it can be hard, try not to take what they're saying personally. They're not thinking clearly, and they're not themselves. A person may or may not remember the experience of delirium afterwards. Some people may be distressed by the memories of the upsetting hallucinations they had or how they acted. So they may need our continued understanding and support even after the delirium has passed. The key thing to remember is to respond to the emotion. The children under the bed may not be real, but Judy's distress is very real. Let's continue with our scenario with Judy and her daughter Karen. Let's imagine that Karen arrives on the scene, but things are pretty tense.
You should have known it was more than a cold. How did you let her get pneumonia? I feel like I can't trust you to look after Mum.
There are lots of labels we could use for how Karen is acting. We could see Karen as aggressive, difficult, critical, unrealistic, demanding. But how might Karen really be feeling? Let's listen a bit more carefully.
I thought Mum and I were managing okay, but this has really thrown me. I'm really busy at work, and now I had to take today off to be with Mum. I love Mum, but I'm feeling overwhelmed. Maybe I should have given up work. How are we going to cope if her dementia has got this bad? Mum had been coughing, and now I feel terrible. I thought she just had a cold. I should have known this was more than a cold. You should have known it was more than a cold. How did you let her get pneumonia? I feel like I can't trust you to look after Mum.
We only heard part of what's going on for Karen. Now we know more. How do we think Karen might be feeling? Well, some of the things that come up for me are that she's scared about what's happening to Judy. She's worried that Judy's getting worse. She's overwhelmed and worried about how she's going to cope. She's feeling guilty. She's feeling that she's failed as a carer. She's feeling a bit guilty about having us as paid care workers involved. What if Judy's just another client to us and we don't really care? It can't be the same care as someone like her who really loves her. She might be frustrated that we, the paid care workers, seem to ignore her or think that we know better. And maybe she's feeling alone, that no one cares how she's doing and no one really understands. And maybe she's angry that her wonderful mother has been reduced to this. Often, when we pause and recognise where someone's coming from, we're more able to respond compassionately. We can respond to Karen's emotion and distress as a daughter, and her love and her concern for Judy. Sometimes people really do feel that they have to fight for good care for the person they love. Anger's pretty normal in this type of situation. It's how people feel when they're losing control and things aren't going the right way. The problem with anger is that we can feel it personally. After all, you can't be angry at delirium, so where do those feelings go? If we get defensive, that can make things worse. Care partners are experts about the family member they support. They know their person's history, their interests, their likes and dislikes, their joys and their fears. The care partners may hold the key to understanding communication and behaviour if the person living with dementia is having trouble expressing themselves. Karen can be a big help while we're supporting her mother. She can spend time with Judy to help her feel calm and connected. We can get her on the phone when Judy's agitated. Karen can help us understand Judy's perspective. For example, that children have been very important in Judy's life as a mother and a preschool teacher. I wonder if Karen knows who Susan is. Karen can help us get to know her mother and what helps to make her feel safe and what interests her. So now we're imagining it's 3 months later and the delirium's long gone. We're still supporting Judy. We've got great communication with her daughter Karen, and we're all keen for Judy to be able to remain at her current level of care. Now our focus is turning to preventing delirium. In Judy's case, preventing another episode of delirium. Sadly, Judy's at high risk because she's living with dementia and she's had a delirium before. Having a dementia automatically puts older people into the high-risk category for delirium, and the more other risk factors the person has, the higher their risk of delirium. Some of the main risk factors the person may bring with them into our care include having a previous delirium, like Judy, poor vision, so that's not being able to read the newspaper headlines even when they're wearing their glasses. Our brains expect a certain level of sensory input, and if our brain is deprived of sensory input, it increases the risk of delirium. Being very frail or fracturing their hip or being severely unwell makes people more vulnerable to delirium. Interestingly, that includes being severely depressed. When a person has these existing vulnerabilities, they're already a bit wobbly. And the more vulnerabilities they have, the wobblier they are, and it takes less to tip them over into a delirium. Even something minor that we might not notice may trigger a delirium for someone who's vulnerable. We can think of the threshold being lower for what it takes to tip them over into a delirium. The most successful approach to preventing delirium is to target the common triggers that might tip a vulnerable person over into a delirium. Anything that can be done to remove a trigger can help prevent delirium. There's a lot of agreement in the research literature about the preventable risk factors we can focus on to effectively reduce delirium. And we can summarise these with a mnemonic: pinches me kindly. So the P is for pain, the I is for infection, N for nutrition, C for constipation, H is for hydration, E is for exercise, S is for sleep, M is for medication, E is for environment, and the kindly is how we do it. The good news is that research shows that when we have a proactive, think delirium environment in place that tackles these possible triggers, we can reduce delirium by a third. The pioneer in the field was Sharon Inouye and her colleagues back in 1999. In the decades since, a number of studies around the world have confirmed that we can reduce delirium by a third. Let's walk through pinches me kindly. First, P is for pain. Judy has severe arthritis in one of her hips, so she's at risk of pain. If we can help manage her pain, we can help prevent delirium. People living with dementia may be less able to communicate that they're in pain or problem solve themselves, so we need to be more proactive. Next, I is for infection. Do you remember that Judy was diagnosed with an aspiration pneumonia? That's one of the most common infections that trigger delirium amongst older people. So Judy's at risk of infection. Aspiration pneumonia is caused when food goes down the wrong way. If you notice that someone coughs when they're eating, raise your concerns. Speech-language therapists can assess whether a change in food texture may help safe swallowing. The other top infectious cause of delirium is urinary tract infections. We may be able to help prevent UTIs by keeping well hydrated, and we're going to look at that separately. N is for nutrition. Even though Judy's recovered from her pneumonia, she's still losing weight and just doesn't seem to have the appetite to eat much. Many older people living with dementia have reduced appetites, and we can think about how to encourage Judy to eat more by making the most of the food experience. C is for constipation. You might be surprised to know that constipation can trigger delirium. Regular toileting and lots of fluids, fibre and exercise can help prevent constipation. H is for hydration. Dehydration impacts on cognition, and as dehydration becomes more severe, it will result in a delirium if it's not caught. When someone like Judy is older and has a dementia, they may be less able to detect thirst. That means we may need to be more proactive about encouraging hydration and not wait until Judy feels thirsty. E is for exercise. We can encourage Judy to keep moving and mobile by encouraging exercise, being open to opportunities to encourage any movement, and addressing anxiety about walking, especially if Judy's had a fall. That movement might help with pain, appetite, constipation and sleep, as well as helping to prevent delirium. And talking about sleep, S is for sleep. A normal sleep-wake cycle helps to prevent delirium. If we're providing support around Judy's bedtime, we can encourage familiar bedtime routines and rituals that help her to relax, know that it's bedtime and time to sleep. A warm drink and a little snack an hour or so before bedtime can be really useful. But even if we aren't around at bedtime, we can still help. Remember, active days help peaceful nights. Activities, routine and company can help a person distinguish that this is day versus that's night, as well as tire them out to help get a good night's sleep. Natural light during the day and darker at night also helps with sleep cycles. We have M for medication. Some types of medication can increase the risk of delirium. So can being on lots of different medications at the same time. Judy's healthcare team may review her medications to check if they're all still needed. Now, some types of medication can trigger a delirium if they're stopped suddenly. So if you notice that someone isn't taking their prescribed medication as intended, do raise the alarm. E for environment. We can help orientate by dropping reminders into conversation about where Judy is and what's going on. We can help Judy use sensory aids. We can make sure that she's wearing clean glasses and her working hearing aids. And we want to help Judy engage in lots of activities, cognitively and socially stimulating things like having a chat or providing some nice sensory input. And the last part, kindly. The fact that we're needed in a person's life generally indicates that things aren't perfect for them. Be calm, be patient, be mindful of them as a person and their emotional needs. Actually, just be kind. When we're stressed, our bodies produce cortisol, and increased cortisol is associated with a higher risk of delirium. So a great environment and kind care can have a physiological impact to help to prevent stress and prevent delirium. These are all things that we might hope we're doing anyway. But Pinches Me Kindly reminds us to be thinking about these things consistently. It's that consistency that helps prevent delirium. Thinking Pinches Me Kindly is also an important part of our strategy when we're managing an episode of delirium. We need to get those triggers out of play. We've covered a lot today. Thanks for listening, and I hope that you go back to work feeling more able to spot a possible delirium, support someone with delirium, and more confident that you can help prevent delirium for the people living with dementia that you are supporting. It's been my absolute pleasure to share this material with you, and I do hope that you can find the time to watch the other Dementia STARs modules. You'll find that there's a lot of material that will help you understand Pinches Me Kindly in a lot more depth. Ngā mihi nui.
We hope you have found this Dementia STARs course valuable. We really appreciate the time you have taken to allow us to share some new ideas and fresh perspectives on this important topic with you. We hope you will return to your work with people living with dementia with renewed enthusiasm. It's such an important job, and you are a very precious part of the dementia family. The New Zealand Dementia Foundation would like to thank CHT Healthcare Trust for their generous support of this project. If you would like to learn more about the New Zealand Dementia Foundation's work, check out their website and join the community. This module is one of a series of Dementia STARs courses. You can find out more about the other topics from your workplace educator or on the New Zealand Dementia Foundation's website. Ngā mihi mai oha. Thank you so much for your commitment to people living with dementia.